Senior Consultant Physician and Rheumatologist from Bhubaneswar, Odisha. So I will be talking on rheumatological complications of diabetes. So as all of you know, diabetes has become an pan-endemic, affecting almost all the countries of the world. And the burden is so huge, and it has become a public health measure. So everybody at every sector, starting from the community to the profession to the administration and government, everybody should be aware of it and act immediately. So coming to my topic, it's the rheumatological complications. We always talk about the microvascular complications, macrovascular complications of diabetes, retinopathy, neuropathy, nephropathy, these cardiovascular complications, but we very rarely, very sparingly, we discuss about these musculoskeletal complications of diabetes. You know, it's very common problem. It may not hamper it may not have the mortality benefit, but the musculoskeletal complications that will affect the quality of life. It increases the morbidity. So we have to act at the earliest so that we can at least prevent or at least improve all these complications. Coming to these complications, the pathogenesis, all of you know, we have this hyperglycemia in diabetics that increases this that age, that is also advanced glycation end products. And this age, when it acts with the cross-linking with the collagen, that becomes the collagen that becomes dysfunctional, and that affects all the muscles and all the periarticular tissue. And also it has been seen this age is also responsible for endothelial dysfunction and also the microvascular complications. So the exact mechanism is not known, but it has seen this age acts through the age receptors, and by that after it activates the age receptors, the intracellular signaling pathway that affects the transcription factor NF-kappa beta, and by that the proteins, the pro-inflammatory proteins, and they are also produced more and more, and they act in the endothelium, that is endothelial dysfunction. So these are the various hypotheses, because these studies are very limited, because nobody wants to at least involve in these things, so that the studies are very limited, and that's why we have the data are very less. Coming to the specific problem, the specific complications, specific components. So what are the specific complications? We have the hand involvement, we have the lower limb involvement, we have the muscles involvement, we have the bone involvement, and the common problems are, number one, hand involvement, we have the stiff hand syndrome, we have the deputance contracture, we have the trigger finger, and in the shoulder there is adhesive capsulitis. So you know the frozen shoulder or adhesive capsulitis. Also we have got the muscle infarction, there is also this. So these are the various complications of diabetes. If I come to one by one, I will just elaborate some 2, 3, 4 complications. Coming to the first, stiff hand syndrome. The stiff hand syndrome, what happens here? These joints, small joints to the hands, they become they stiff. There will be waxing and thickness of these joints, mostly the proximal interphalangeal joint and the metacarpophalangeal joints. So there will be difficult in the grip. There is also difficult in the fine movements. So if you have, there are some, these are all clinical diagnoses, and if you have this prayer sign, we have got a prayer sign, we have also a tabletop sign, prayer signs. If you just oppose both the palms, so normally we can flatten the palms, both the palms, but in case of this stiff hand syndrome, what happens? There will be difficulty in flattening. So because the metacarpal joint, the proximal interphalangeal joints, these are stiff. That's why we cannot. So this is called the prayer sign. We have the tabletop sign. If you put the palm on the table, you cannot just press, you cannot have contact of the palm to the table. So there will be like this. So because it is stiff, you can have. So these are the signs. So these are the clinical signs you can diagnose this problem. Coming to the treatment, you see, we don't have a satisfactory treatment. In many cases, they are also irreversible. But if you can, from the very beginning, if you have a good control of blood sugar and you can have just physiotherapy, then you can have physiotherapy, you can have occupational therapy, and in some cases, the intralesional steroids that also help. And very rarely, the surgery also helps. So these are the various treatments of Stephan syndrome. I will come to next to Dupuytren's contracture. Dupuytren's contracture, it's a, we have got the palmar fascia. So this palmar fascia, there is fibrosis of the palmar fascia. So that what happens? The palmar fascia, there is fibrosis. So there will be nodules, and that will have contracture of the pharyngeal, this metacarpophalangeal joints. So there will be like this, and the palmar fascia will be stiffness, and there will be nodules. There will be also bands on the palmar fascia. So what happens here? You see, there can be also coexistence of Dupuytren's contracture and Stephan syndrome, but at times it is difficult to how to differentiate. Typically in Dupuytren's contracture, the lateral two fingers, the ring finger and the fourth finger, these are the fourth and fifth fingers are mostly involved, whereas in case of Stephan syndrome, mostly these radial three fingers, they are mostly involved. So again, coming to the diagnosis, again the diagnosis is, if there is nodules, then you can have at least you can inject corticosteroids there, and there will be some relief. And this is better, treatment is better in this of Dupuytren's contracture than in Stephan syndrome. I will come to next another common problem, that is trigger finger. All of you must have marked, also come across trigger finger many times. So in trigger finger, what happens? Again, we have got these flexor tendons. These flexor tendons, they have got some pullage. There are annular pullage, there are also cruciate pullage. So there are many pullage along the tendons. You might have find about 7-8 pullage. So there is A1 pulley, that is an annular pulley that is present in over this metacarpophalangeal joints. Above the tendon is there and the pulley is above that. So when there is a disparity between this tendon and the pulley area, that is, there will be already a catching sensation, because there will not be freeness of movement of the finger. So what happens whenever somebody wants to either flex or extend, there will be a catch, there is a snap, and the finger will be like that. So you have to again manually extend it. So this is the trigger finger. This is very common problem, and this is also very not only common problem. This is a very the quality of life here also many times, if it is repeated and if it is bilateral, then it is hampers the quality of life, hampers also fine working. So here again we have got treatments. You have to do exercise it, you have to do physiotherapy, again intralesional corticosteroid over that pulley, that also helps. There also you can have a splint also. You can have some splint in the primarily, that also help in the early stages. Coming to the next, you can have a carpal tunnel syndrome. This is very common problem. You must have come across many times with the carpal tunnel syndrome. This is found in the general population also, but in diabetes, because there are certain problems which are very specific to diabetes. There is only one, there is muscle infarction. But all these problems, what I am describing, these are associated with diabetes, and the incidence is much more than the general population. So coming to carpal tunnel syndrome, you see, as you know, the median nerve passes through the carpal tunnel. So for the carpal tunnel, also there are many tendons, all the flexor tendons, they also pass through the carpal tunnel. So here happens, there is a compression of the median nerve. That causes problem in the hand. So this is carpal tunnel syndrome. Here happens, the median nerve is compressed. So you see the lateral, the radial 3 fingers, and also the radial part of the 4th fingers, these are affected. So this is the affected area. What happens? there will be also pain and tingling and paresthesia of this area. And the most problematic is it hampers the sleep at night. This pain is worse at night. That is the most problematic of this carpal syndrome, and more advanced cases that can also affect the motor problem. There will be thinning of the weakness and thinning of the muscles supplied by the median nerve. So, if we can, these nerve conduction states and the MRIs, these are also helpful in cases where difficulty in diagnosing. So, coming to treatment, yes, there are some clinical, you can just staging in the early stages. There is stage 1, stage 2, stage 3. In the early stage, what happens? Only there will be paresthesia, and it doesn't hamper the, there will be no sensory loss and doesn't hamper the nocturnal sleep. But in the intermediate stage, there will be definitely at times the nocturnal sleep is hampered, and also there may be minimal sensory loss. But in the severe cases, what happens? Severe cases, there is sensory loss, there can be motor involvement, and the nocturnal sleep is much more hampered. Patient cannot sleep throughout the night. So, in the early cases, we can have at least splint. We can use a splint. We can also give intralesional corticosteroids, and that people more and more people they recover. But in the severe cases, we should also send for surgery, so that there will be the decompression surgeries are there, and we can send to that. So these are the some hand problems. We can also the shoulder problems are there. There is one more common shoulder problem. So in shoulder we have got adhesive capsulitis, or what we call this frozen shoulder. There is also rotator tendinopathy. So we can adhesive capsulitis or frozen shoulder is a very common problem. That also happens in other conditions, but in case of diabetes, it is much more concern. It is a very painful condition. In the early stage, there it has got 3 stages. Here the glenohumeral joint capsule that is affected. So in the early cases, because you have got 3 phases. In the early phase, that continues for 4 to 8 weeks. So during these weeks, the pain will be more. Patient will have pain, both active movement and passive movement, both are very painful. So this stage again go to the intermediate stage. In the intermediate stage, what happens? There is more and more of stiffness of the joint, but the pain gradually recedes. But there is more of stiffness. Then that also continues for 4 to 8 weeks, and finally, the last stage that goes from 10 to 24 weeks, and the stiffness persists, but there will be some gradually in the early stage, but gradually there will be recovery. So this is a self-limiting disease. In many cases, definitely it is being cured automatically. It is a self disease. But what happens? In many cases, also the residual stiffness that continues. So we can give from the early stage. You can give and treat the patient with limited movement. You can have intra-articular corticosteroids, and gradually in the second stage, third stage, you can go for physiotherapy. So these are the various problems that we find, but there are many other kinds. So my message is, you see, we should not at least debar these rheumatological complications from proper investigation, proper treatment, and early diagnosis. And if we diagnose these patients early and treat early, we can at least give a patients a good quality of life. Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.